CEO.
Good morning, Jacqueline Johnson, Chief Operations Officer.
Are you joined by anybody else?
No.
No, I think our clinical director might be here in a little bit, but she has appointments back-to-back this morning, so she's going to try to make it in as soon as she's able.
Okay. All right. Thank you. So, well, I just want to go over the agenda briefly. I just wanted to first briefly tell you about the purpose of the call. Then I wanted to get a sense of why your organization was interested in joining this project, and just some other background about Caring Health Center, just to help us get a better understanding of who you are and who you serve. And then it sounds like we might want to switch, since your clinical learning leader is not here right now, it looks like we might want to switch the assessment interviews. We normally start with a clinical. It sounds like since that person's not here, it would be better to do that at the end. Are you okay with that switch?
Yes, we actually see her from the window. She's hurrying across the street.
Okay. Well, I mean, I'll check in after we hear a bit from you about how you want to, what order you want to go in. And we'll, of course, do a performance improvement review of your responses to that section, have a brief discussion if we have time, and then discuss next steps. All right.
Okay.
Have any questions before we move on?
No?
Okay. All right, so, I mean, just briefly, I just want to let you know the purpose of the call, and that's just to review some of your responses that you've provided within your assessments and confirm your responses and be able to ask more information on the performance improvement side. It's going to really help them be able to develop some initial work plans and project plans so you can then begin to do some work. And then on the clinical side, it just gives us a better understanding of what you have working with you and some of who we'll be working with. So we're just trying to get comfortable with your organization, just to get to know you right now at this point. And, okay. All right. So then, in terms of some background, we just wanted to just know a little bit more about Caring Health Center. We have your application and your assessment, but that's not a lot of room to tell us a lot about who you are and the types of populations that you serve. So we just wanted to get some background about your organization, get a sense of why you wanted to apply, and what you hope to achieve through this project. And I'm not sure who wants to start from your end.
Okay, I'll start. Caring Health Center is a federally funded 330 community health center. It was funded in 1992 and has grown ever since. We currently have two sites, one with medical and dental, both with adult and pediatric primary care. And we have many prevention programs. We serve 14,000 patients with about 49,000 visits. One of our specialty clinics is infectious disease, and we've had a lot of success following HIV-infected individuals and with Hep B and C care. It's a multidisciplinary team with RN, MA, an infectious disease provider, medical provider, and other supports as needed, including social case management. Because of trends nationally and in the state, we have begun to move away from a freestanding clinic, and over the course of the next year, we'd like to integrate our HIV care into all just primary care so that all of our providers feel comfortable and equipped to handle patients with HIV. We're treating it as a chronic disease, so our providers see people with cardiovascular disease, with asthma, with diabetes, and we would like them to do the routine primary care for patients with HIV. We're well integrated in the community healthcare system here in Springfield. We have one large teaching hospital with many specialties, including adult and pediatric infectious disease, and a smaller acute care hospital. We work well with them. We'll be able to refer our patients with HIV for consults and technical assistance from the specialists in the community. And we feel that it's an improved model of care, kind of where, as with many health centers, moving into the medical home model, and we see this as kind of destigmatizing and kind of normalizing the care for our patients with HIV. While staff is interested in this, some are more excited than others. We knew that we had kind of a huge training challenge to getting all of our providers, nurses, and medical assistants kind of feeling competent and confident that they could do this. And Jacqueline noted the training opportunity with you. We scrambled to get our proposal into you, and we were absolutely thrilled to receive notice that we were approved. So I'm not sure if I didn't cover some aspects. Just ask us, and we will respond in more detail.
No, I think you've hit on every single thing I would want to know. I do. It's wonderful to hear that you guys are trying to destigmatize HIV and really integrate it into your regular primary care practice and really treat it as a chronic disease. I do want to follow up on something in your application and your assessments. You do receive Part C subcontract monies?
Yes, we work with Holyoke Health Center, with River Valley, with Bay State, and receive subcontracted Ryan White monies. I should mention that Vanessa Washington has joined us, and she's our Director of Clinical Services.
Great. Welcome.
Good morning. Thank
you. Welcome. All right.
I didn't really break down our patients, but it's one of the things that keeps people thrilled with working here. We have a huge diversity of patients with about 40% Latino, mostly of a Puerto Rican background, about 20 to 24% African American, 20% Caucasian, and the balance is African, Caribbean, and refugees of various backgrounds. We are the largest refugee health assessment site in Massachusetts, so our wait rooms really look like the United Nations. HIV has been a huge medical risk for refugees, and we're able to pick up and work well with them because we have a very kind of culturally competent staff which reflects the people that they're serving.
Great.
Wonderful. Thank you. And did you move further away from the phone?
No. Did I? No.
Yeah, no, it just sounded like you just sounded more distant. Okay. No, that's wonderful. Thank you. Sorry, I didn't hear that.
I said we'll lean in when we respond.
Okay. All right, thank you. No, very interesting to hear all of that information, and I'm sure we'll be probing based on some of the information you just provided throughout the rest of the interview. Now, I mean, like we said, we can do whatever you're more comfortable with. We can start with the review of the clinical training assessment first, now that Vanessa here, or we can lead with the performance improvement, whatever makes you more comfortable. Do you have a preference?
No.
Okay. Well then, we'll move on to the clinical needs assessment.
Okay, great.
And I'm going to let Stefan, our HIV specialist, go over that section.
We're just having some technical difficulties.
All right, there we go.
Oh, there we go. Okay. Alrighty. Good morning. This is Stefan. It was great to hear about your site. Thank you for sharing all of that. I'm going to briefly go through some of the components here of the clinical training assessment, which I think Vanessa, you filled out, and you did a great job. So thank you for working on this for us. This is really going to give us sort of an overview of your training needs, and then I'm going to also briefly go through some of the next steps, including give you an HIV overview of the HIV training package, and also what our self-assessments look like, because at the end of this call, I'm going to be sending you self-assessment forms for you to give to your care team members that you've listed on this on this training assessment, in hopes that you'll have them fill them out, and then you can send them back to us, and that will give us a more in-depth overview of where the training needs are for both your individual providers and care team members, but also sort of the care team as a whole. So briefly, we're just going to go through the training needs assessment at this point, and it looks like you have about 84 HIV patients on your census. Is that correct?
Correct.
Okay, great. And it says that the specific sites that you want to focus on, or the specific populations, include women recently incarcerated and substance abuse, but it also sounds like you have a pretty significant refugee and immigrant population. Would you want to maybe add that to your specific focus?
Yes.
Okay, great. Okay, and moving on to your care team list, I was just looking through them, and it looks like you have quite a few pediatricians on here. Are you planning for do you see any pediatric HIV cases?
Currently we do not, but we plan to.
Okay. Our HIV...
We've just been... the Mass Care grant to Massachusetts was previously funded by DPH to the teaching hospital, and it is shifted to us effective January 1st.
Okay. Okay. And that was January 1st?
Yes.
Okay, great. Our training package doesn't actually have any pediatric HIV training, so to speak, but if that's something that's a specific need for your team, that's something that we can try to work out as we go forward with the mentoring aspect of the training and working with your local AIDS Education and Training Center to get some PEDS curriculum on board. And I can certainly also work with the nurses around specific pediatric and HIV issues, as that is part of the ANAC curriculum that's available to them as well. So just as a little bit of an aside there. But it looks like you have quite a robust clinical team, so that's great, and quite a robust nursing team as well. And is one of these nurses the nurse that's dedicated to the ID clinic?
Yes, that would be Tracy B.
Okay.
Under the registered
Great.
nurses.
Great. Okay. And I see also your LPN MA list as well, which is great. We definitely have a curriculum for for those participants. Now, do any of the participants here on your care team list, do any of them currently see any HIV patients?
Yes. The first provider listed under providers, Catherine B.
Okay. Is she the one who staffs the ID clinic?
Yes, with Tracy.
Okay, so she's the actual ID.
Yeah, we have a board-certified infectious disease specialist, MD, who consults to the clinic every week. He's not seeing the patients, but he's supporting the team.
Great, and you have your NP Catherine B. actually seeing the patients. It sounds like.
Yes.
Okay, awesome. And she is a staff on staff at your site?
Yes.
Okay, great. Okay, great. All righty. So just moving forward then, I see that you also have a lot of dentists, and I remember you saying that you do have a dental practice as part of your site. And while, again, we don't have specific dental training per se in the HIV training package, there are some proficiencies that deal with oral health and HIV, and also we can offer them a foundational curriculum that they can move through that will give them sort of a broad overview of HIV, including some specifics around epidemiology and disease process and things like that that they might find valuable. So that's great. I'm glad you included them there. So in terms of moving to the next page with the HIV care capacity question, this is where we asked you to sort of stage your site based off of your care delivery model. And you chose supported care. And that's what it sounds like based off of your one staff member who's providing HIV care. But you mentioned that the other staff on your care team currently are not providing HIV care. Is that correct?
Correct. That is correct.
Okay. Do any of them see HIV patients, like if they come in if the patient wants to be seen for an urgent visit or has a chief complaint of sore throat or something? Are they ever seen by any other providers, or are they only scheduled in ID clinics?
No, they are seen, for urgent or walk-in needs, and as Ann has already mentioned, we're moving towards all of our providers having the capacity to be able to see them. But currently,
great.
Be seen by other providers.
Okay, great. And the only reason I ask is that sort of helps me a little bit better stage where you are in terms of all your providers, whether or not they're currently seeing any of the HIV patients or none at all. So that's great. So then I definitely think that you do fall within the supported care or perhaps the collaborative care area, but you definitely are providing a high level of care, it sounds like, to your ID patients. And you also placed yourselves at stage 1 in the clinical stages, which is the next question, question 6. And I think that based off of what you said, I would go ahead and agree with that statement at this point because your other providers are seeing some HIV patients on a walk-in basis, but probably they would need to complete what we call our stage 1 curriculum in hopes of maybe moving up the ladder into a stage 2 provider where the providers would feel more comfortable managing some of the antiretrovirals and doing some of the chronic disease management that you all were talking about integrating. So I'll go ahead and agree with stage 1 for that, which is great. Okay. Did you have any questions about those questions, about the staging and the models of care delivery?
No, we would agree that currently we are at stage 1, but it is our goal to advance to stage 2.
Okay, great. Great. We can. That's what we're here for. So, and then it says you haven't participated in any HIV-related training in the past 12 months. Okay. And let's see. And you've identified Mindy Dome for your mentoring and clinical consultation. And where is she located?
They're out of South Boston.
Okay.
This is Jacqueline speaking. I got a hold of them via the Mass Care Director, the Ryan White Part D Director.
Okay.
We had asked for some training assistance, and they had put me in contact with Southeastern AHEC. And in addition to them, I'm also working with, I guess it must be another component of another unit branched out of you guys, working with Jim Minigan. I don't know how to pronounce his last name, but we're working with Mindy Dom out of Southeastern AHEC, and then we're also working with Jim, who comes out of your specific organization.
Is he at AETC?
Yes. Yes.
Okay. Probably does the Northeast AETC sound familiar?
Yes.
Okay. Great. And then
I'm working with the overall the people at the very top looking to provide MD to MD training.
Okay, great. Okay, great. Do you think that any of the ID providers that you currently work with might also be interested in providing mentorship, additional mentorship or clinical consultation if we helped bridge that gap?
Yes, I do.
Okay, great. I'm just going to tell Christine that they were interested in maybe their own ID providers or some of the ones they are working with, also helping out as mentors.
Oh yeah, where does your contracted ID specialist work, or the one that comes in?
The one who comes in is at UMass Medical in Worcester, and he did his ID training at University Hospital in Boston.
Okay, thank you.
Great.
He's very good.
Okay, great. And what's his name?
What's his name?
Habir, Harbir, is the first name. Sawhney, Sawhney.
And does he actually come on site to see patients, or is he kind of a telephone consultation?
Occasionally he has come on site, but for the most part, he gets a faxed printout of all of the clinic schedule each week, and he talks directly with the nurse in the clinic and the provider, Catherine Burchell. He talks with them patient by patient before each clinic session.
Oh wow, great. Okay. Okay. Great. So moving right along to the training plan questions, it sounds like you do have some regularly scheduled provider meetings, and those are once a month during lunch on Mondays. And do you see these as a time that you may be able to incorporate some HIV group training?
Definitely.
Okay. Okay, great. We know that sometimes that meeting is often pretty busy for providers, especially, or for the whole staff, especially when they're only once a month. There's a lot of information to cover. But if you're willing to work with that time, that's great. I think we can definitely develop some group trainings on a group training plan there.
Yes, we devote part of every one of those to a training topic. And we can strip the entire meeting of business and do just training. And if we had enough lead time, we could extend it to be like a 12 to 2 or just shorten the afternoon session. But we would need, of course, lead time to keep the patient bookings.
Yeah, definitely. Definitely. Great, great. And how much time do you normally have for training during those meetings?
About 45 minutes.
Okay. Oh, that's great. Okay. Okay, great. And So I know you said early on that sometimes the buy-in can be a little bit difficult from all of your providers, which is very common, I think, in health centers when bringing on sort of a new specialty. So do you have any idea about how your providers might tackle some of the self-study portions of this training that might be available?
We don't know.
Yeah, we're not.
Okay. Okay. Well, we're going to go over the training package in just a minute here and look at exactly what the training encompasses. So it might give you all a better idea of how to approach once you know exactly what the training will entail. So we will, actually, we can move into that right now. And let's see, do you have any questions before we move on to the training package overview?
No?
Okay, great. So we're going to talk about the HIV training package, and basically what this is an overview of sort of the HIV training that you all are going to be participating in over the next year. And this is the training that's going to assist you all with getting your health center and your providers from that sort of stage 1 capacity of delivering HIV care up to the stage 2 level. So this is how we're going to do it. So what we'll do is we'll go quickly through some of the roles and responsibilities. We'll talk a little bit about the stages of HIV integration and the models of service that we've developed. And then we'll talk about the HIV training itself. What we're going to help you do throughout this is provide guidance around clinical learning and training. We're going to conduct some and evaluate your site and use some individual assessment tools to help facilitate the training. And then we'll provide assistance with developing training plans that will help fit the goals and capacity of your health center in particular. And this is one of the areas I think that we could work together very well, because our hope is to really give you as much as 6 months lead time so that you know what training is coming up. If we start in May, you'll know what training is coming up in September. So as you said, you can adjust your schedules as needed. So we really do hope to give you quite an advanced training plan so that you have it planned out for what trainings you may need to review and do as a group well in advance.
Great.
In terms of the clinical learning leaders, and this would be you, Vanessa, really what your role is going to be is to serve as the liaison between the health center care team, those providers that you've listed on your care team list, and us. And also you're going to be developing, of course, with our assistance throughout the whole process, but really developing and overseeing the clinical training plans with the assistance of our team. We'll work with you to define a schedule for training in conjunction, obviously, with your health center leadership, and then communicate with us. Our lines of communication are always open, but we ask that you bring any of the needs or concerns of your care team to us so that we can help you through the training process. And let's see here. In terms of the care team members themselves, your clinicians, their responsibility is obviously going to be to participate in the training. And the time commitment issue, of course, again, will be determined by the clinical learning leader as well as the leadership team. So that will all be sort of to be determined. But the individual piece will really be determined by the provider. And when we go through the actual curriculum, you'll see that it's very flexible, it's very self-directed. So the providers can really determine where they need to focus their time and which learning proficiency they need to spend more time on. And then they'll be also responsible for monitoring their progress for their individual training and then completing the evaluations. And actually one of the other pieces that I didn't put on the clinical learning leader roles and responsibilities is also going to be an evaluation piece. So that's going to be very important, Vanessa, that you're going to be sort of the ringleader when it comes to making sure that the evaluations get done, because as you know, with any federally funded program, we have loads and loads of evaluations, but we're really working hard to make sure that the evaluation process is really streamlined for your providers so that they don't have to spend a lot of time filling out paperwork for the purposes of their training. So the community care continuum is really a way to stage the capacity for HIV care, and it consists of two ways. One of them is the stages of HIV care, which we've talked about a little bit, and you've rated yourselves as stage 1, which is on-site management of stable HIV patients who are ARV naive or on first-line ARV therapy, and then management of common complaints. And that's why I asked about, whether or not some of your other providers have seen or do see HIV patients. It really does put you right in that stage 1 category. And then we have our integration models, where we look at how that care is being delivered. So, and I think you're probably right there either in collaborative HIV care or supported HIV care. And really the difference between the two is the level of clinical consultation needed. So collaborative care would require more clinical consultation, and this may be the case with as you start to transition some of your staff providers over to seeing these HIV patients. They may fall into that collaborative HIV care model, where they're really counting on their consultants a lot more frequently. They're using consultation much more extensively, whereas your NP Catherine, who's already seen these patients, she may be in the supported HIV care where she's providing quite a high level of HIV care with clinical consultation as needed on an as-needed basis. So I think you're fine right where you are there. And really what these two do is they allow us to kind of build a framework around developing a strategy to take you from where you are and move you up one level, and that's what you're seeing in front of you right now, is that correlation of the models and the stages. So our approach to training is really using what we call the HIV training package, and it's really to provide a set of learning resources for the CHCs to build or expand your care and treatment. It's assessment-based, it's self-directed and self-paced, it's very flexible again. It's accessed through an online website called the Virtual Learning Lab. It's also available in hard copy form, which we will give to you when you come in April for the community meeting. And we'll also go through a much more in-depth training around how to use the Virtual Learning Lab and how to access the care team, how to access the curriculum via the Virtual Learning Lab. So bottom line is that it's all online, or we can give it to you in hard copy form. It's sort of a one-stop shop for training. All of the resources are already in the VLL. They're already in the curriculum menu, so your provider just has to go into the Learning Lab, click on the proficiency that they want to learn more about, and everything is right there for them at their disposal. It's the training pack is again a multidisciplinary approach, so it provides curriculum for providers, nurses, LPNs, and other support care team members. We have a set of basic and core resources. Core and supplemental resources. The core resources are the HIV/AIDS Bureau Guide for clinical care, obviously the DHHS guidelines for antiretroviral therapy, and then, as I mentioned before, the ANAC core curriculum. Then we also have a webinar series that we've developed as well that's very useful for your group learning activities. Each learning proficiency also has AETC resources, online CME resources. There's over 74 CME opportunities available in the training package, so that's very nice for your providers. They can sit down and complete a proficiency and also complete a CME activity that's associated. And it provides direct links to all of the specific information right there on the page, so they don't have to navigate multiple websites. So the training itself is broken up into curriculum menus, and each curriculum menu corresponds to a specific provider or provider level. So for instance, each provider has their own, each clinician, I should say, has their own curriculum menu. So providers, for instance, in stage 1 have their own curriculum menu. RNs have their own curriculum menu. LVNs have their own curriculum menu. And then support staff or other staff in the health center have their own curriculum menu, which is foundation stage. These curriculum menus are also broken up by clinical stage. So for your providers, because they're stage 1, we would give them they would have access to, provider stage 1, both parts 1 and 2, and then also provider stage 2, so that they could complete those proficiencies associated with the more advanced HIV practice. Again, it's sort of one-stop access, and I'm going to kind of move through here. It's available in 2 formats. One is the Word document, which you see in front of you right now. As you can see, it's this is for the provider stage 1, and it's diagnose and manage acute retroviral syndrome. So as you can see, the core resources are available in PDF file, so that they can just click on this one particular link and access just the pieces of the guidelines and just the pieces of the manuals that are pertinent to this specific topic around HIV care. And then there's some supplemental information available as well. I'm going to hang on one second. In DC, we never know if it's the president flying over us in a helicopter or what exactly is going on, but something's flying over us right now. Moving forward, we have the curriculum menu also in an Excel version, so this is just a little bit visually different, but all of the same resources are included here. One of the other pieces that I want to just sort of talk about before I move into the monitoring framework is to really sort of help you understand exactly how the training package is broken down. So we talked a little bit about curriculum menus, but within those curriculum menus are proficiencies. And these are the actual proficiencies that are associated with the topics of HIV care. So each curriculum menu has a set of specific proficiencies that we've determined are necessary for your providers, whatever particular stage they're on. So for instance, provider stage 1 curriculum menu has, I'm not sure off the top of my head, but maybe somewhere in the ballpark of 35 proficiencies that are associated with that. So your provider would choose which proficiencies they want to go through, work through those proficiencies, and then record that on what's called the monitoring framework, which takes us to what you're seeing in front of you. Now, the monitoring framework is basically just a framework for your providers to keep track of what they're doing in the training package. So as you can see down the left, the monitoring framework has all of the proficiencies that are associated with that provider, and then it allows them a place to sort of keep track via checkboxes on exactly how they're accessing, whether or not they've accessed the learning materials in the proficiency, whether or not they've completed reviewing all of those learning materials in the proficiency, if they've discussed it in group or during a training plan, and if they've received any mentorship or, in your case, any consultation around that. And then whether or not they were actually able to apply that proficiency in the scope of patient care activity. We talked a little bit about the virtual learning lab already, and it is password protected, and we'll talk more about how we can get you access to that and get all of your care team members their passwords as well. There's some supplemental tools available that are available in the virtual learning lab as well as in the curriculum menus. Again, these are CME activities. There's also some point of care tools, patient education materials, and those kinds of things that are available to your providers. So before I finish up here, I want to briefly go over the self-assessment, and this is a really, really, really important piece of what's coming immediately after this call. So I do want to kind of highlight this here, just take a few more minutes and do that. These are the self-assessments that we asked the clinical learning leader to pass out to each of the care team members listed. Now, I see that you have quite a few medical assistants and LPNs listed on your care team, and that's fine. You can certainly give all of the care team members that you've listed on this list the self-assessments, as long as they plan on doing the training that's associated with it. And the reason I say that is because in 6 months, we are going to be giving you another set of self-assessments, and we're going to be asking those same care team members to now rate themselves after 6 months of training on some of these proficiencies. So it's going to be very important that we have consistency based on who's getting these self-assessments now, who fills them out and returns them, because we're going to be doing the same thing in 6 months. Obviously, we know there's probably, staffing changes and things like that, but for the most part, we want to try to maintain some consistency. So if you look at the provider self-assessment that's in front of you, a few things that I want to highlight here. It is the first set of questions here are dealing with some demographic data that we are asked by our funders to include. And also up at the top, you can see there's a place for the full name of the provider as well as the credentials and specialty, and that's very important for us to know if the provider is an OB or if they're a women's health nurse practitioner. That's important for us to know, as well as the site. So that we know that, you I think, for instance, said that you have 2 sites. So it's important for us to sort of help keep track of where the providers are. And then a place also for their email address. That's also going to be important for the evaluation process, because that's how we're going to be able to email the online evaluations to your providers. So just make sure that when you're describing this to your care team that you also hit those points as well. So the actual self-assessment looks like this in front of you. Each of the self-assessments have a foundation stage where the provider can rate themselves in terms of foundation proficiencies. So there's 2 main pieces that your providers or your clinicians need to fill out. The first one is column A, where we ask them to rate their competency in a specific area. And up here you can see what that criteria is. So rating themselves as a 1 would mean that they're unable to perform that proficiency. Rating themselves as a 2 would mean that they're able to perform that proficiency with direct HIV expert guidance. So this is probably where a lot of your providers may fall in some of these proficiencies. A rating of 4 would mean that they're able to provide that proficiency independently, and perhaps your NP, who's already seen a lot of HIV patients, may have a lot of proficiencies where she feels that she's at a 4 already. So that's column 1. Column 2, or I'm sorry, excuse me, that's column A. Column B is the area where we ask the provider to check whether or not they would like this specific proficiency in their individualized training plan. So say, for instance, I'm going to fill out this as a provider, and I take number 1, the first proficiency, explain the natural history of HIV disease to patients and families. So I feel like I'm a 4. I can do this without the need. So I would put a 4 here, and then I would not check that box because I don't really need to learn any more about that. I feel like I'm pretty competent. However, when it comes, if we scroll down and we see, let's say, proficiency number 7, for instance, provide comprehensive prevention for positives education. Well, I'm actually not as familiar with that. So I'm going to rate this as level 1 for me, because I don't think I could do this proficiency without some training. So I would put this as a 1, and then I would check the box there to say that I would like that as part of my individual training plan. And we sort of use that in 2 ways. We use that in the first way to sort of help guide the clinicians if they need any extra assistance with developing their own individual training plan. And we also use that because we're going to collect all of these self-assessments again and sort of collate them for you, run some data for you, and then we'll be able to say at the April meeting, well, you know, Vanessa, I'm looking at your care team here, and 75% said that they wanted, in the foundation stage, they wanted proficiencies 2 through 7 on their care plan. So that may be something that we can help guide your group training towards. Whereas on the other hand, maybe only 10% wanted proficiency 1, so we would say that's probably not a great use of your group training activity to hit that proficiency. Does that sort of make sense?
Yes. So you'd like
okay.
this to be done by all providers before we come down next week, or in a
yes,
couple
so yeah, so all of the members that you've listed here on your care team on the training needs assessment. So yes, and just remember that for the providers, and I'll send you the assessments that need to be completed, but your providers will need to complete provider stage 1 and provider stage 2 self-assessments. Your nurses will need to complete the registered nurse self-assessments, and your LPN, LVN, MAs will need to complete the LPN MA proficiency self-assessments, excuse me. And then your dentists and your, if you have any unlicensed supportive personnel, like, I don't know if you have like an adherence counselor or anything like that, they can fill out the foundation self-assessment. So I will send you all of those with some instructions on how to do that. If you could send them electronically in a Word, have them be filled out in a Word version and then send them back electronically, that would be best for our evaluation team. But obviously, however you need to get them done is fine. Just let us know. And what we've been telling the clinical learning leader is if you could sort of be the ringleader and passing them out and getting them all back and sending them all to us at one time, that would be great. Is that something you could do, Vanessa?
Yes.
Okay, fantastic. So I think that's it for me. Do you all have any questions in terms of the clinical training and next steps around the self-assessment?
No.
So you're going to send it electronically? Right?
Yeah, I'm going to send these in a Word file, a Word document, so they can be sent. They can be sent out to your care team members in a Word document as well.
How soon?
I will be sending them probably around 1 o'clock today, as soon as this call is done. Yeah, and if you could
getting physicians to fill out forms.
I know. Believe me, I know. Yeah, I totally understand. So I'm going to get these to you as soon as possible. We do ask that you try to get them back before the community meeting, because that way it will give us the best chance to try and get the data compiled for you so that it's as meaningful as possible for you when you come, because we will ask to start developing your training plans at the meeting. So if it's possible, I know it's really difficult to get everybody together at once or to get them all back from everybody. So we just kind of ask at this point that you try your best.
Okay.
Okay, and any that you can't get done, you can just bring along with you to the community meeting and we'll try to incorporate them in. Okay, great. So I'm going to step back here and...
No other questions on clinical. I think we'll just move on to the performance improvement section. And Sarah or Therese, which one of you are going to be leading first?
I'm going to be leading first, Therese.
Okay, well, let me make you a panelist. All right, so you should be able to...
roll.
I'm not seeing anything. Still on the, if you're changing anything, it's only on your screen.
Oh, okay. Yeah, it's changing for me, but...
Oh, there you go. Sorry. There you go.
Great. Okay, so just going to move to the performance improvement section. I'm going to be covering the first half, and then Sarah's going to be doing the second half, and we're just basically following up to questions that were in your self-assessment. So for the first one, under revenue maximization, so what's your payer mix like, and what's the kind of breakdown of your patient population in terms of insurance coverage or not having insurance coverage?
We're in Massachusetts, which has been very successful at enrolling people, so our uninsured patients is about 3%.
Okay, great.
That's amazing.
We have mostly public insurance reimbursements, probably for about 78% of patient visits, and the balance would be the small number of uninsured and other insurance providers. We're credentialed with 19.
Okay. Great. Yeah, that's so great that the uninsured rate's so low. So I see from the next question, so you don't track the percent of rejected healthcare claims, although I see, like, reading later on that it looks like you do have a process to address rejected claims. So can you tell me a little bit more about that?
No, wait, that should be a yes.
Okay.
Yeah, I'm not sure. We have a sophisticated billing department, and they follow every individual denial and appeal it and document. If we're ultimately unsuccessful, it's documented, and we do some training around coding and so forth to try to maximize reimbursement.
Okay, great. So, do you offhand do you know the rate of rejected claims or not?
No,
okay.
We could get that easily.
Okay. Okay, great. So, okay, so you, so then for 22, that should be a yes as well? You have a report on why healthcare claims are rejected?
Yes.
Okay.
Yes, we do.
Okay, great. And then, okay, and then you do training on coding, so I'm assuming 23 is also a yes? Does your health center currently have a process?
Yes.
Sure. Okay.
Yes. Providers are completely involved in the process. We have an external billing and coding company which comes in once a year and does chart audits and presents to the providers about common errors. They aggregate the response so that individual providers are not singled out, but we know who they are, and if they need further training, we will do that individually. All providers are trained initially as they come in on Massachusetts billing and coding.
Okay, great. Okay, so thank you for your very detailed answers for the next few questions. It sounds like you have a pretty standard process for collecting payment from patients. So is there any particular area that you would like to work on in regards to revenue maximization? So mostly with the other, most of our other health centers are not in Massachusetts, so their uninsured rates are pretty high. So we're probably going to be working with them on how to collect at least some payments from uninsured patients who can afford it, as well as, training on coding. So, but I don't know if there's something else that would interest you to work on.
There was something on the previous thing about our providers confident about their ability to code to obtain the maximum
the relative value
unit. That would be helpful for all of us. We are cautious about not over-coding or under-coding and striking the balance so that if we're audited by any insurance companies, we're compliant. So understanding that specific to HIV/AIDS work would be very helpful.
Okay, great. Okay, so yeah, have the providers been trained on coding for HIV at all?
No.
Okay, great. Okay, so I'll put that down as what you would like to work on for this section. Sarah, do you have any other questions on this section?
No, I think it pretty much covers it for me.
Okay, great. So we'll move on to quality improvement. And, okay, so my first question was, do you offer universal testing currently?
Universal?
Yeah, is HIV testing offered to each patient?
It is offered, and it's a part of the primary visit. It is encouraged, but then in addition to that, we do provide confidential HIV testing.
Okay.
Are you actually doing, at this point, opt-out screening for your patients, in the sense that patients are just offered HIV testing as part of the routine services, and then they opt to not get tested?
Yes, it is offered as part of their care, and the patients have the ability to opt out.
Okay, gotcha.
Okay. All right. So you listed annual CPE and those on heart and CDC recommended care per the Red and White guidelines. So specifically within those areas, do you have any goals in mind that you want to work on?
Within the patients that are currently on heart, the goal is that those on heart, that they would be have undetectable viral loads.
Okay. Okay, and then, so I mean, that sounds more like a clinical goal. Do you have any, you know, operational goals around that would support maybe your clinical goals?
Well, our operational goals are actually developing with the new grant that Ann had mentioned that we received in January. So operational goals are going to be increasing the knowledge and the skills of all of our providers and providing HIV care to all of our patients.
Okay. Okay, and then, okay. So, okay, so for your quality improvement committee structure, is there, so I see you put down monthly meetings with managers and supervisors from all departments and are chaired by the clinical services director. Is this meeting for QI specifically, or are other things discussed at this meeting?
That meeting is specifically for quality improvement throughout the health center, throughout the agency, and then the specific departments, they have their own monthly meetings, and part of their meetings will also discuss quality improvement.
Okay, great. So do you plan on including your HIV work through this grant in those meetings?
Yes, it will be included. And that's where we will develop, you know, performance measures around the clinical care for our providers.
Okay. Great. Okay, and then for the budget period renewal performance measures, what kind of measures are included in this? And you know, could you give maybe some examples of you know, how this was used to determine a quality improvement priority?
Well, our budget period renewal measures are measures throughout the health center from our dental department, finance, human resources, clinical, and operations. And an example of some of the clinical measures would be patients who have hypertension, you know, what their blood pressures are, if they're controlled, diabetes, those patients receiving the standards of care for diabetes. Included in those clinical measures are the two HIV measures for the patients that are part of the Ryan White, having to do with those on heart, and also we're measuring whether those clients receive a CPE, a complete physical, every year. Those are just clinical, and then there are human resource measures related to patient staff satisfaction, operational measures related to the statistics and follow-up on patients that do not keep appointments. So these are from our budget period renewal that we have to report on annually, and so they're like the foundation for our quality improvement measures. But they're not our only quality improvement measures. Then each department develops other measures that may not be specifically identified or stated in the budget period renewal.
Okay. Great. Noting that.
Okay.
Okay. And then have you done any quality improvement around HIV services specifically?
Not so much as a part of the committee, but maybe like hiatus and some of the...
Yeah, in some of the QA/QI meetings we've had, I've provided some measures that we're looking at in the smaller HIV program, which is called Digetis. It's a program focused on Latina women who are intravenous drug users, and so we've looked at referrals, we've looked at confirmation of those referrals, and we've also looked at the risk assessments that they fill out. So those are some of the measures we've been looking at and assessing.
Okay, great. And how long has that been going on?
We've been looking at it since the model changed over the past year, so it's been about 7 months.
Okay.
The program has been program's been in place for 11 years, but with a new model that we picked up through the state, we're looking. The numbers look a little different, so the measures changed up a little bit.
Okay. All right, great. Yeah, we'll try to include any. We can talk more in detail about the program, or if you want to incorporate some of those measures into your QI for this project as well, so that you're not working on very siloed projects or goals overall for HIV care. And moving on to the PDSA. So you have used PDSAs. Do you use them often or not often?
We've used them. The departments are encouraged to use them anytime they're instituting change.
Okay, so how often would you say that is? Like, do they use PDSAs on, a daily basis or just for, sporadic, specific initiatives?
More for specific initiatives.
Okay.
I think with the PDSA, it's something that you do, but unless you actually, write out the steps, it's something that you kind of do in your head even before you realize that's what you're doing.
Right. Yeah. Right. Yeah. So I guess that we're asking more about, the actual writing it out, and that.
Right. Exactly.
That's more for. Okay. Great. And then for my only other question on 29, what is so HealthStream? I looked it up. It seems a little bit more hospital oriented. How is this incorporated into your primary care?
They do have a lot of the programs that are hospital-oriented, but we search for the ones that would be more applicable to our health center setting, and that's just one of the sources that we use for, online trainings.
Okay. What topics does that include?
We've used it for their performance improvement. We've used it for sexual harassment, violence in the workplace, HIPAA.
Okay.
And they actually have a couple of programs on HIV that our Ryan White team has reviewed.
Okay, great. Okay, so is there something specific that you would like to work on in this area, so quality improvement around HIV services?
I think specific areas are kind of going to be covered in the goals that we talked about earlier for our clinical team, and advancing them from that stage 1 and making them more proficient and competent in providing HIV services.
Okay.
And I know that's kind of broad, but something in that area is definitely a goal what we're working toward.
And it's going to be helpful. Our hope is that, having them provide feedback individually on where they're at, being able to develop their own curriculum on their needs so that everyone feels like they're being able to learn at their own capacity. I think it's going to be really helpful.
Okay. Okay. Sarah, do you have any other questions for this area?
Nope, I'm good. Thank you.
Okay. All right. So we can we'll move on to cultural competency. So, let's see. So it sounds like you do some training on HIV-specific cultural competency. Is that just for specific staff that work on with HIV patients, or is it for all staff?
It's for all staff.
Okay. And that includes like front desk and billing anyone who...
Everyone. We did a huge project with George Washington University around, Georgetown. So we were designated as a center of excellence for cultural competency. And I think we do very well in the area of racial, ethnic, but we have not done anything around sexual orientation, gender identities, and that is emerging as a need. We have staff and patients who have expressed an interest in that.
Okay, so that would be something that you would want to focus on.
Definitely.
For this. Okay, great. And would you say at your health center, is there, stigma around HIV? Do patients generally feel comfortable disclosing their status, or, receiving HIV testing, or is it kind of more, they're hesitant to and don't usually feel comfortable talking about it?
That varies. It varies. You have some that are more comfortable, and then we have those that, are not. And we recognize that, and so, we try to meet patients where they are and, help them through it.
Yeah, and I think it has to do with some of our integration of our models because they've been different models. I think once we're getting trained around integrating full HIV services into primary care, patients will start to see that sort of transition happening. And so right now there's programs that are very specific for HIV patients. And so I think it's just a matter of letting it be known that it's an integration model that we're developing here.
Okay, and like the patients would be, you think they'd overall be receptive to that? Or do you see some potential issues, either among your patient population or even among providers that maybe don't feel comfortable asking about HIV status?
I think that most of our providers are comfortable with asking about it. But in the past, because we had our infectious disease team that then took care of the patients who identified, they didn't have that responsibility. So now getting them comfortable with providing the care.
Okay.
I had a question about the patient satisfaction survey. Is there a patient satisfaction survey within the infectious disease clinic that's different than the one that your patients get in primary care? I guess we're trying to figure out specifically how patients are responding to your HIV services.
Well, because our patients, even though they may be seen by the HIV team, they are patients, so they may fill out the general patient satisfactory survey, but there is a patient survey specific to that team that is a part of the Ryan White program.
Okay.
Great. And then I noticed on question 33, so one of the challenges you listed was languages and medical providers. Can you elaborate a little bit more on that? Is it a problem getting translators or not having enough staff that speak the languages of the population?
Well, we have so many different languages, and we do have translators for most of those languages. And for the languages that we do not, we have a interpreter line that we can use. But because of the nature of the information discussed, using an interpreter or even using the language line can be challenging.
Okay.
So I think that's more of our challenge.
Okay.
What language? Sorry, Tracy.
Sorry. Are most HIV/AIDS patients non-English speaking?
Currently, a lot of our HIV patients, a lot of them speak Spanish, and we do have Spanish people on the team, so that language isn't as much of a challenge. But
African languages.
Yes, we have African languages.
Okay. Great. Sarah, did you have another question?
That was my question. Thank you.
I do think, again, we should add to that the provider comfort with lesbian, gay, bisexual, transgender people, because they are not, I think there might be some assumption that they aren't there among our patients, and they surely are.
Is there currently any kind of conversation in your patient assessment about gender identity and sexual orientation? Do you ask, is that something that's asked as part of your assessment?
The HIV team, they may ask that as part of their assessment, but not a part of our general assessment, no.
Okay.
Okay. So I'm going to put, just to summarize, that for this area, you would like to work on like cultural competency around sexual orientation and gender identities, making providers more comfortable dealing with the LGBT population, and then also for the providers that maybe haven't had as much experience with HIV-infected patients, just making, addressing their comfort level and seeing if any improvements need to be made among those particular providers. Is that correct?
Yes.
Okay, great. So I'm going to hand it over to Sarah, who's going to ask about the next few sections.
Trace, do you mind just kind of scrolling for me? Is that okay? So we don't have to. Thank you. Okay. So we're going to move on to recruitment and retention. So with this question here, barriers to recruiting people living with HIV/AIDS into care, this is talking about what barriers your healthcare center has faced in getting those folks into your practice. Are there currently, in your experience, are there currently barriers to getting folks into your practice, or, can you talk a little bit more about that?
Yeah, as noted here, we have plenty of health fairs. Patients can walk in, anybody can walk into the health center to access any of our HIV services, and we oftentimes do HIV testing in the community. We also do very intense community outreach Monday through Thursday from the early hours of 7 a.m. to typically around 11 a.m. to recruit some of the highest targeted populations at risk for HIV. So the services are being provided. However, there are some barriers that have come up in terms of like transportation, or oftentimes it's transportation or the populations that we're dealing with, just inability to get here, whether it's, for example, I'm speaking about the intravenous drug user population that we really deal with. Oftentimes, they don't feel good, or it will take them some time to turn around to actually walk into the health center.
Mm-hmm.
But it's not so much in terms of them, a lot of the reports we get back, it's not so much that they don't feel comfortable once they get here. It's a matter of them just getting here.
Mm-hmm.
So that's,
right.
And I know we have a public transportation system here, but, with that too, who's to say if they can afford that and what that sort of process looks like.
Okay. Okay. And in terms of your community outreach to the highest risk populations, you mentioned intravenous drug users. What other populations are you trying to target right now with your outreach program?
Intravenous drug users, specifically Puerto Rican women, adolescents, women, and women of childbearing age. That's just changed over the past 4 months. We just implemented the adolescents and women of childbearing age. We also try to target more recently. There's been a push from the Department of Public Health to recruit MSM. And that's about it for now, unless they walk in through the front door and word of mouth. But those are our focal points right now for the HIV program.
Okay, great. So in terms of your, how does your, can you give me a little bit of a picture of how your outreach program works? How many staff do you have working on it? You mentioned you go out into the community physically, but could you just talk a little bit more about the program?
Sure. So Monday through Thursday, we did an assessment back about maybe 9 months ago around how outreach was working, and the city of downtown Springfield, during the day, there's a lot of professionals, and so people who we were looking for in our target population just weren't out at that time. So we transitioned, and we were doing outreach at that point from 12 to 4, and more recent, over the past 7 months, we transitioned it to being from 7 to 11 in the morning, and so they go to the local train tracks where people hide out and, oftentimes shoot up or do whatever, they do their business there. We do outreach at the local shelters, outreach at the local bus terminal, which has been, over the past 5 months, like a booming area. So that's been some feedback we've gotten there. We do outreach at the open door pantry, both of the food pantries in the city. We do outreach at one of the churches here in downtown Springfield, and we do some outreach at an apartment complex that it has an inside area and an outside area, but it tends to be highly populated with folks at high risk for HIV. So we cover the whole downtown city area, but it's 2 outreach workers, and one of them happens to also be a patient navigator. So if a patient feels that they are having I forgot to note that earlier, if a patient feels like they're going to have some trouble navigating the health center or getting to their appointment or something, that patient navigator can help them in that process. And her position she's just transitioned over to the clinic, and so it's starting to really pick up her presence being there and helping patients navigate the health center. Okay, great. So I guess the other question, here on the assessment was, trying to just, talk about your efforts to ensure that your patients living with HIV remain in care. And it sounds like you've got the Ryan White nurse and social worker really working closely, with the providers to make sure that happens. How do you currently have a way of knowing or tracking how many of your patients are kind of meeting that goal of, having 2 visits per year or being in care with your providers? Are you tracking that?
Yes, we are.
Okay.
We have a database. We have the old Ryan White database as well as the CareWare database. So the adherent social case manager and that nurse, they track that information on a monthly, quarterly basis. Okay, great. So in this area, it sounds like you're doing a lot of, you're assessing yourself and you're really reaching out, physically to really high-risk populations. Is there something that's specifically here that you would like to improve upon? Any measures anything that you think of with this project we could help you improve around?
Actually, I have a couple questions.
Okay. Yeah, of course.
So is your health center mainly where patients with HIV and AIDS in your community receive care?
No.
No, okay.
You said, let me just make sure, you said, is our health center the main place where HIV patients receive care, right?
Yeah, in your community.
No, and that can be, or could be a barrier because we collaborate and we affiliate with the largest teaching hospital in the area, and a lot of our past work has been in conjunction with them. So people may think that they have to go through Bay State in order to get HIV care, which is not correct. We are standalone, and we can provide those primary services.
Okay. And so has this been a challenge thus far?
Yes.
Okay. Does the hospital generally refer patients?
Well, up until currently, they do not, because they also provide the same services. But as of the 1st of January, when we received a grant that they had for 20 years or so, you know, they had no reason to refer to us. And like I said, we worked in conjunction, and a couple of our grants, we were on the grant together. But now that things have changed and we do have this grant, they have not, as of yet, started referring to us, but they will need to because we are not able to provide services that they can no longer provide.
Okay. All right. Yeah, that's definitely something we'll need to consider with our work in this area. Okay. So sorry, Sarah, back to your question.
Yeah, no problem.
Yeah. Yes, what would they like to work on, and what would you like to work on in this area, particularly?
I was hoping, one of the things I was hoping maybe we could get some help on, I think over the years as the population just becomes, their needs just become so different, you know, we don't have someone to, like, sit and do, like, a full assessment of, like, the city and what these needs are. I'm just hoping we can get some help around, like, how to strategize, how to pool, whether it's our care team together or how to pull our outreach workers together, our case managers, to figuring out, like, what are the, like, very basic assessments we can do just to figure out where people are at in their HIV needs in the city. Because they're changing so often that, you know, sometimes we feel like we're 5 steps ahead and then the next day we're 2 steps behind. And it could be from something of lack of transportation to I forgot about my appointment, you know, so, and it happens in waves. So I'm just hoping that we can get some sort of strategies or assessment tools that can happen, you know, over a short period of time for our staff here to be able to assess, you know, what are these HIV patients' needs, and how do we want to incorporate that into the larger health center in terms of thinking about our whole patient population needs.
Okay, great. That's definitely something we can work with you on, so thank you for bringing that up. Okay, great. So then we'll move on to access appointments. So right now, you know, for 38, for example, what are your health center's goals around appointment access? And you had said that your Ryan White appointments are managed by your Ryan White case manager. So I guess I'm just, you know, curious as to how that system is different from your general kind of practice. And did you want to, you know, whatever's working there, would you want to bring that over into the integration model with working with your HIV patients when they kind of come over to your primary care providers?
We will not be able to rely on that one nurse as she's doing now, but with her help and assistance and working with the other nurses, we may still need the assistance of a nurse kind of ensuring that these patients get the appointments in a timely manner. And because sometimes, you know, we have to kind of work with their schedules or their willingness to receive treatment, you need, you know, a little bit more help than we might for our other patients. But because we are integrating their care with all of our providers, you know, it won't look like it did when you had the one nurse doing this.
Right.
So they need some extra help and support of the clinical staff to make sure that they do get appointments when they're willing to receive care.
Right, right. So this is something that you're a little bit concerned about, that, you know, with the integration of these patients into your general primary care practice, they may not get the kind of the specialized TLC that the Ryan White nurse has been giving them?
Not that they won't receive it, because they will, but it will be coming from someone different. So they have to make that adjustment.
Okay. And currently, how are things working with appointment access? Do you have open access, for example? You know, how do you keep your panels open for walk-ins? How is that structured currently?
We do have open access in that patients can walk in and they will be seen by a nurse, and if needed, the nurse will pull in a provider. Or they'll be scheduled, you know, if it isn't super urgent, they'll be scheduled to come in the next day or so for the provider. We are a health center that is hideously crowded. And in June, we begin construction on a new facility, that will expand both medical, dental, and prevention program space. It's access to appointments for new patients is difficult. It's at least a 6-week wait for a CPE.
Okay.
So we really, I think what we would be using the training for is we're poised to grow. We have 14,000 patients, and within 3 years we'll have 28,000 patients. So how do we manage that, and how do we open up appointments as we begin to get the exam rooms to add more providers, and we have the capacity to see people. So it's going to be complicated. I mean, the health center is expanding lab services, adding radiology, so we'll be more equipped to see a range of all kinds of urgent care patients besides HIV patients and the ones who come in.
You said the construction start happening in June. What's the expected or anticipated time frame for that? I mean, these are things I always run over, but what are you thinking of in terms of the construction?
June 2013 will open.
Okay.
And do you have a practice management system to do appointment scheduling?
Yes.
Okay, and that's the same uniform throughout your sites?
Yes, it is. Well, dental is a little different, but they interface with each other.
Okay.
Okay. And who is at the health center is responsible for tracking your appointment access measures? Or, I mean, I guess for example, cycle times. And ensuring that patients are able to get their appointments, and when they're there for their appointment, that how long it takes them to see a provider. Is that currently being tracked, and if so, who's doing that tracking?
Yes, it is being tracked. Operations and our front office managers collect that data.
Okay. And how often is that data collected?
Monthly.
Monthly? Okay.
Yes.
Great. Okay. And have you undertaken any efforts, to date in terms of improving appointment access, around wait times and, I mean, do you have open access? So maybe that was an initiative that you all undertook. But what were some of, what have you done to date around improving your appointment access?
The triage line, the triage nurses, as well as looking at provider schedules. Sometimes, double booking or just, making changes in the provider schedules to make more availability.
Right.
The most recent one was implemented this week to hold a couple of refugee health assessment slots to ease. There's a time limit on getting them in and getting their 2 assessment visits done. So we did that to improve our accountability on that.
And then also calling patients. We call patients the day before their appointments, and to ensure that they're coming. And if they're not, then that opens up appointments.
Okay. Okay, great. Thank you. So I mean, I heard before in terms of the area of improvement, it's really the idea that soon you're going to be, well, you are already growing, and you're going to be growing even faster in the future. So how to keep your access measures kind of relevant to what's going on with the overall practice, and how large you're going to get, and how many services you're going to be expanding to. Anything else that I was missing there in terms of what you would want to work on in terms of access or appointments?
I would like to hear other ideas of how other health centers that mirror a health center like us are doing it. Effective tools, like how are other people doing it to maximize revenue but also provide effective care to patients?
Okay, so case examples, absolutely. We find that's one of our main ways that we try and how we try and organize our training is to offer you real world examples of what other people are doing in the field. So definitely we can do that. All right, and the last section is reporting and population management. So currently you're not using an EMR system. It sounds like you're about to go into the EMR world. You still have you're still looking at different kinds of systems. Is that right?
Yes.
Okay.
We have 3 finalists. We've met with 2 of them. As soon as we meet with the 3rd, we'll be making our decision.
Okay. And do you have a possible time frame as to when you think you might roll out an EMR system?
Well, by the fall, we would be implementing.
Okay.
I don't think it will be fully absorbed, digested for at least 9 to 12 months.
Right. Now these things take a long time in stages of going live. So, yeah, and so you're using a data management. You're using a practice management system, and with this practice management system, is there, or with things like Excel programs, are you able to validate the data that you do get? So is there a way of making sure that the number of patients walking through your door is the number of patients walking through your door, or that the information that you're getting through your management system is valid?
Yes, and there's a capacity called
Practice analytics
that you can request special reports.
What is your system called? The practice management system. Which one are you using?
Sage Medical Manager.
Sage. Okay. Okay. And just moving to, does the Sage Medical Manager system, report kind of a list of reports that you all review on a regular basis? Is there kind of a category of report, a catalog of reports that you all look at?
Yes, and we can, create, if there's a specific report that we need. So there are some standard reports that have already been created and saved that we look at on a, monthly basis. But then from time to time something may come up and we can, put in what we need and it can create a report for us.
Okay, great. And do you have the ability to do cohort reporting where you're looking at, one specific subset of your patients? For example, HIV patients within your Latina, like you have a certain program. It sounds like you're kind of doing that already, but you have like a subset of patients that you're trying to make sure that, your interventions are working with the Latina kind of intravenous drug user group? Or is that something that you're trying to that you can look at specifically with your reporting system?
If we were talking about our HIV patients, in addition to our practice management, we have the CareWare program.
Okay.
So if we wanted to run a report on the patients on heart and what their viral loads were, we'd have the capability to do that.
Okay, great. Okay. All right, just moving right along here. So I'm going to moving along to the patient registry kind of portion of the reports kind of section. So it sounds like you utilize patient registries to identify patients who may need tests or may need follow-up. Who are your staff that are assigned to work on patient registries?
Currently, specifically to the HIV program, it would be Tracy, our Ryan White nurse, and the adherence social case manager who works with her.
Okay. Okay. And I think, I guess I have another question, too, that's related to the Ryan White piece, but just to finish this up, is there anything, Trace, do you have any questions around reporting and population management before I kind of move on to the area of improvement?
No, I think No, is your so do you have your practice management system, and then you also do you have a separate registry for your patients? I know you have the careware, but in general.
What's the question?
Do you have a separate patient registry system?
We used PECS in the past for diabetes, but we're not using that currently.
Okay. So what are you using currently?
The only registry that we're using right now would be the careware and Ryan White database, but the electronic records that we're looking at, they will definitely have a registry component to it. Okay.
Great. So I guess is preparing for that something you would want to work on how to use, you know, an EMR with population management and reporting?
Yes.
Okay.
Okay. Was there anything else that you thought you might want to work on in the area of your HIV patients, HIV services, with how you use your reports, how you manage this population?
Nothing we can think of right now.
Okay. Because it sounds like, I mean, you're also about to transition into a whole different system. So as Trace was saying, we can definitely try and kind of prepare you for what that's going to look like in the future. And I just had one, I know that we're at time here, but I had a question about the Ryan White program with your Ryan White nurse. When you move towards integrating your infectious disease patients into primary care, is that nurse going to retain that kind of status as a Ryan White nurse, or is she going to be more integrated into primary care as well? How is her role going to change? Or the people who are working specifically with these patients, how is their role going to change or stay the same as you move into integration?
During the transition, she will assist in helping the other registered nurses to become more comfortable with caring for HIV patients. And she'll always be a resource, but eventually she will be integrated as well.
Okay. So she can be your in-house expert, but then she's going to be, her job description or her role will not be any different than any other nurse at your practice?
Somewhat.
Okay, yeah. Okay.
I think she'll always be seen as an expert, kind of floater.
Yeah, because that's definitely, I mean, that's something that you can, I think having in-house experts among your staff is a really great way of making sure that these things are, you know, are sustainable. So, great. That's basically, those were the questions that I had for the performance improvement piece. And we are at time. So, Christina, do you want to come back in at this point?
Yes, thank you. Let me just go back. Does anybody have any questions? Because before we go on to just discussing next steps. No? Okay. Well, as next steps, probably after the community meeting, we'll begin assigning your health center some staff contacts on our end. So you'll have a coordinator who's essentially going to be air traffic control. If you ever need anything, have a question, don't know where to send something, you can send it to that person. A clinical coach and a performance improvement coach. In terms of the clinical next steps, Stefan mentioned earlier that he will send self-assessments. I don't know if you received them just yet. I saw him trying to go over to his desk while on the call to see if he can get self-assessments to you, but they will be to you today, so don't worry. And then at the community meeting, you'll begin your training plan. And I know, Anna Watt, I know that we have your travel. Do we have travel? Have the rest of you booked travel so far?
Yes, I'm waiting on a confirmation from the travel agency. They've had some major difficulty getting us to, Vanessa and I wanted to stay till Saturday, and for some reason there's no flight coming in on Saturday that's not booked. and so they
Wow.
want to stay for the second part of the conference, but it's just not letting us. So the travel agent made it clear that he had a 5-day window to try to see if anything opened, and he's saying he's trying everything, but, you know, I explained to them we really want to stay till Saturday, and as it looks right now, Vanessa and myself are flying out on the 18th in the evening, and we're trying to come back that Saturday afternoon or evening, whatever, but there's nothing available. So right now, it looks like we might be coming back on Friday, which is too bad because we really wanted to be there on Saturday.
Oh, no. Did he try Sunday? I don't know if that's an option for you.
There's nothing on Sunday. We would have preferred to come back Saturday evening. He's saying that there's just nothing coming in to Hartford. It's all booked. He said he's tried first class. He's tried shuttling us to BWI, and there's nothing. So he said he'll call me today by 4. So that
okay. Would you be open to taking the train? I know that's not as... And I don't mean to take up your time right now on this. I'm just trying to think of options. Okay, yeah, I think they did communicate that with me. Well, I'm hoping he'll find something so you guys can stay.
Yeah, that would be because one of the options was that we leave on Saturday morning, but it defeats the purpose for that. We just leave Friday evening.
Right, right.
It costs all this extra money to keep us there an extra night and then to fly out the next morning. So we're in the pocket.
Okay. Well, I'm sure he'll keep trying. Yeah, sorry to hear that. We'll definitely see what they can do. And then, Sarah or Therese, did you just want to talk about the next steps on the performance improvement side?
Sure. So we're going to be compiling your answers to the performance improvement topics that we discussed on this call, and then from those coming up with goals for your project plan. And then we will reach out to you to schedule an hour-long conference call to discuss the goals and make any changes and make sure that you're okay with them. And that will happen before the community meeting. So look out for an email from either myself or Sarah.
Okay.
All right. Well, thank you all for joining us and spending so much time. And sorry for the technical difficulties at the beginning. I'm glad you were finally able to get on. If you have any questions, feel free to reach out to Jarrett. He had to step off to go to another call with one of your fellow health centers. We definitely look forward to seeing you at least at the community meeting. Hopefully we can get you on a flight so you can stay for the rest of for our second meeting. But again, it's a pleasure. We're looking forward to working with you throughout the year and look forward to meeting you in a couple of weeks.
Thank you.
Thank you.
All right, thank you. We appreciate your time. All right,
Take care. Bye-bye.
Bye.
Bye.